I want to present our experience with PeTEP technique for primary ventral hernia repair. We didn't have disclosures. The big evolution of minimal invasive abdominal wall surgery started when Jorge Dice introduced ETP for inguinal hernias. Later, Dr. Belyansky adapted this concept for ventral hernias through the PeTEP ripstopper technique, and the next development, in my opinion, is PeTEP technique proposed by Hector Valenzuela from Guadalajara. What's the indications of PeTEP? It's primary midline hernias, defect size 4 to 6 centimeters, and you can completely reconstruct linea alba if patient have concomitant diastasis. And we can see first publication with early results with PeTEP technique from robotic and laparoscopic approach from Hector Valenzuela, Victor Radu, and our colleagues from Spain and India. What is the benefits of PeTEP? Why we decided to perform this technique? The most common benefits, this technique preserves abdominal wall anatomy. You don't need to divide it to sterector sheet, so the possibility damage of nervoscura blundas, linea alba is excluded, and mesh in preprinal position, minimal contact with vessels and nerves, so potentially reducing bleeding and pain. And we have excellent overlap and midnight closure comparable or exceeding PeTEP ripstopper. What is the disadvantages of PeTEP? Of course, it is the risk of peritoneal tears, especially when you, in initial part of procedure, when you can damage your peritoneum, lose your working space, and sometimes need to convert to another minimal invasive surgery. And sometimes it is a difficult procedure, so one of the disadvantages is steep learning curve. Now in the world we have two variants of PeTEP. It's suprapubic or bottom-up approach, is classical Valenzuela technique, and cranial subxiphoid approach. This is a modification of our Spanish colleagues. When you when you perform suprapubic approach, you start suprapubically and go upwards, and when you start perform cranial approach, you start subxiphoidally and go downwards. Important detail of surgical anatomy in this technique is fatty trident described by Miguel Orena, and when you perform bottom-up classical Valenzuela technique, you have three zones of dissection. First zone is retsu space, second zone is preperitoneal midline space, and third zone is right and left pretransversalis space. The most necessary case steps of this procedure is patient position. Second is the port placement, preperitoneal space creation, dissection laterally in pretransversalis space, closing peritoneal defects if you need it, and linea alba reconstruction, and in the end mesh placement in preperitoneal pocket. Very necessary in this procedure is the position of the patient. This is photo by Hector Valenzuela. This is extending position. We stay between the legs, and I need to say that you need to moving the legs of patient in different parts of the procedure, because maybe in 90% they have a conflict with patient legs in a different part of the procedure. In the central photo, it is port placement for classical Valenzuela technique, and in the right side it is a port placement in our modification when we start implementing this procedure. The first 10 or 12 millimeter trocars was inserted above symphysis. 2 centimeters we use open technique. Also you can use optical trocar like Hector Valenzuela or Victor Radu. And after that we start to optical dissection in the right side and the left side to create our working space for our first 5 millimeter trocars. And when we insert first trocar, we complete dissection in zone 1 in the retsu space for our second 5 millimeter trocars. All trocars was inserted lateral of epigastric vessels. And here you can see port placement and surgical pin position during classical PeTEP approach. One of the difficult parts of the procedure, for my opinion, it's create your initial working space and install your trocar. Because in such cases, we damage the peritoneum, we need to convert to another minimal invasive approach. So we decided to use one of the left or right recto space, like we typically do when we perform ETP for inguinal hernias. So we continue our optical dissection in zone 1, place our first trocar, and continue completely dissection in red seal space, completely in zone 1, and install other trocars in a safety situation, and complete our dissection like classical Valenzuela techniques. In most cases we use left rectal space. Sometimes if patient have, for example, history of LAP, TPP of left inguinal hernia, we use right rectal space, and this first trocar we use for optics when we perform simultaneously inguinal hernioplasty during PeTEP. After that, we continue dissection in zone 1 for zone 2. Between posterior rectal sheet and peritoneum, upstairs we have arcuate line, posterior rectal sheet, downstairs we have peritoneum. And from my opinion case, mostly important case steps here is transected medial umbilical ligament. When you transect this ligament, the place is open up. Very necessary how you install your working trocar, because if you install a mole over, this part of procedure is very comfortable for you, but uncomfortable when you perform dissection granularly. Sometimes it's impossible. So if you install your trocar more higher, this part of procedure is uncomfortable because you're working like this position. The goals, slide peritoneum, remove peritoneum from posterior rectal sheet. Sometimes we perform medial to lateral dissection, sometimes sequence may be changed, and we go granularly, maximal granularly, and you can see peritoneal defects, but our space is not closed because the peritoneum is very soft, elastic than posterior rectal sheet. And if you have patients with M1 and 2 hernia, you reduce the epigastric hernia and go subxiphoidally or subdiaphragmatic. And after that, we continue dissection in zone 3. It's pretransversal space. When you're in a cleavage plane, the better use blunt dissection, sometimes cut some fibrous tissue. The goals you need to see transverse muscle. Sometimes we use traction, contraction, and the depth of this dissection depends with size of diastasis and the size of hernia defects. Contraction like this. And as I say, we perform nine inguinal hernioplasty during PeTEP. We use optical trocar from one of the rectal space. And when we perform critical view myopectinal orifice, we place anatomical dynamics. After that, we can reconstruct linea alba. We suture linea alba with diastasis and defects from C4 to suprapubic, use one called V-lock. Suturing peritoneal defects with V-lock 3 or light V-lock. Sometimes better use the V-lock. This is review after dissection, suturing peritoneal defects, and reconstruction of linea alba. And after that, we can use a mesh. We used for this situation macroporous dynamesh. The size of mesh was 22, 26, 12 to 17 centimeters. We position mesh in preperitoneal pocket from subxiphoid to suprapubic in M1 hernia from retroxiphoid. We do not fix a mesh and perform desufflation under visual control. But we have some challenges when we implement this technique. It is not, I said this, it is not simply technique. First challenges is the damage to the peritoneum during initial trocar placement and initial working space. Our solution use right or left rectal space, especially when you leave an incurve. Second, incorrect position of your working trocars when you impossible or difficult to perform high quality dissection and suturing of linea alba. Our solution install only additional 5 mm trocars lower or higher, and continue your preperitoneal plastic. And third, this is extensive damage of the peritoneum. Our solution, don't panic, continue your dissection if possible, mobilize the peritoneal suture without tension. If it impossible, converts to another minimal invasive surgery. This is a short video. I do some mistakes incorrectly take my part. I won't go with transversalis, but do a very big defects of peritoneum. Take two additional trocars on the left side and left side, and continue my dissection maximally, cranially, laterally, in pretransversal space, because we need to suture peritoneal defects without tension. This is a pretransversal dissection in the right side. This is the lower part of right edge of defects, and this is the lower edge of defects. And after that, we put our optics at 12 mm trocars and easily suturing this all peritoneal defects with free or V-lock without tension. You can see how easily we can suturing the peritoneum, because peritoneum, as I said, is more elastic than posterior tissue. This is the position when we suturing peritoneum. We try to perform 27 PeTEP, 20 patients with diastasis. Patient we need to convert to another minimal invasive surgery because we damage the peritoneum in the initial part, and we perform 9 simultaneously inguinal hernioplasty during PeTEP. Short-term results with this operation, we didn't have intra or post-operative complication. Average hospital stay is 2 post-operative days. Y score was maximal 5 of 2, and follow-up 3 months, 6 months, and 1 year for some patients. No signs of hernia recurrence or diastasis. With Y score, satisfaction 10 of 10, and with EURA quality score, European Hernia Society, PeTEP technique leads to rapid and durable patient satisfaction. So our conclusion is that PeTEP for primary ventral hernia repair is with diastasis is safe, feasible technique, but sometimes it's a difficult technique. The possibility to perform PeTEP with simultaneous inguinal hernioplasty in one space. The most critical steps of the PeTEP is the creation initial working space and place your trocars. During the learning curve, first consider the possibility of creating primary working space on the right or left retractor space. If necessary, if you need, install additional trocars. And short-term post-operative follow-up after 3 months, 6 months, and 1 year demonstrated high patient satisfaction with this technique. Thank you for your attention.